When I was in medical college about 55 years ago, a very famous movie came into the theaters, and that was The Good, the Bad and the Ugly. And Clint Eastwood was the very famous hero those times, appearing many in Western movies. And I thought of using this metaphor and applying it to the diabesity and the fat distribution in diabesity, using the word the good, the bad fat and then ugly fat. Here in this picture we have seen the subcutaneous fat, the visceral fat and then the intra-organ fat, that is the intramuscular fat and the intrahepatic fat. In diabesity, fat storage definitely matters, but it matters more to look for the location. So the location matters the most, where the fat is stored. The good fat is the subcutaneous fat. We have been listening to metabolically healthy obesity since morning. You will find that it is the subcutaneous fat that is very important. So does metabolically healthy fat really exist? What is metabolically healthy obesity? Raised fasting insulin with normal fasting glucose. We all know that whenever fat is required to be stored, it requires insulin. So insulin goes up, but the fasting glucose does not go up. Normal blood pressure, normal lipid profile and lack of systemic inflammation. So these are the criteria which distinctly set it apart from the unhealthy obesity. And what is the pathophysiology behind MHO? The dietary fats are deposited as subcutaneous fat except the saturated fats and the trans fats, and also depends upon the lifestyle, and the genetic factors also play a role in the deposition of the fat. What are the diagnostic parameters of diagnosing this metabolically healthy obesity? So imaging, CT, MRI, DEXA scan and the body bioelectrical impedance scans. Using these modalities, we can find out how much is the subcutaneous fat and how much is the visceral fat, and we can find out the ratio of visceral adiposity to the subcutaneous adiposity. The ratio should be less than 0.4 normally. The waist to hip ratio is our old clinical friend. We all do it in our clinical day-to-day practice. Waist circumference is also a very important parameter of assessing the visceral adiposity. Biochemical markers, these are the increase in adiponectin. Adiponectin happens to be the good hormone. Then the GIP also increases, PPR gamma increases. So these are all the biomarkers for the metabolically healthy obesity. Many research studies, longitudinal and cross-sectional studies have shown that healthy obesity does present, but it may be a temporary phenotype. Most of the healthy obesities gradually degenerate into unhealthy obesity. That is the bad obesity, that is the visceral fat. Visceral fat in this cartoon you will find it is inside the body, that is the trunk. So what is visceral fat? It gives rise to metabolically unhealthy obesity phenotype of obesity. It is inherited genetic tissue insulin resistance. People who have history of diabetes in their parents usually will have insulin resistance inherited in the liver, muscle or adipose tissue in the form of mutations in the enzymes they are required for storing the fat. Excess of carbohydrate intake is a cause of acquired metabolically unhealthy obesity. De novo lipogenesis happens to be the most important thing which gives rise to endogenous obesity. So whenever we eat fatty substances, it goes and gets deposited in the subcutaneous fat, gives rise to healthy obesity. But when you take more of carbohydrates, it will give rise to de novo lipogenesis, increase post-meal excursions of triglycerides and VLDL. It will cause increased leptin, GLP-1, IL-6, TNF-alpha and PPR-alpha. What happens is that the adipose tissue, the visceral adipose tissue will secrete leptin, whereas the subcutaneous adipose tissue will secrete adiponectin. But when visceral fat is being formed, what does visceral fat do is that visceral fat will displace equal amount of subcutaneous fat. And this subcutaneous fat has no way to go out of the body. Please remember that whatever carbohydrate, water-based things we eat will be excreted through the urine if it is more. But when we eat more of fats, the fats cannot be excreted in a water medium. So the fats have to be used up, and otherwise the fats have to be converted into a water medium, that is ketone, and then it has to be excreted. And therefore, whenever this good fat gets lipolyzed, it will come in the form of free fatty acids into the blood, and it will be stored in the liver, it will be stored in the pancreas, it will be stored in the muscles, and it will increase the insulin resistance there, and therefore the fasting insulin will increase and glucose will increase. It will raise HOMA-IR. The subcutaneous fat also will increase HOMA-IR, because HOMA-IR is a product of insulin into glucose. There, glucose does not increase, only insulin increases. Here, glucose and insulin both increase, giving rise to a marked increase in the HOMA-IR. What are the studies, evidence from the studies? The clinical and epidemiological studies tell us that high carb diet and increased visceral adiposity give rise to metabolically unhealthy obesity. Liver DNL activity and fat distribution are important. Experimental and animal studies have shown, using the rodent models, and the high carb diet and enzyme upregulation shows us that during high carb diet, acetyl-CoA carboxylase and fatty acid synthase enzymes are upregulated. The isotope tracer studies have shown that tracing the fatty acid origin, whether it is coming from exogenous source or whether it is being produced inside the body, will be found out by doing an isotope tracer studies. So differential fat storage, DNL derived fatty acids are found in VAT. So whenever they have studied VAT and the content of VAT, they have found that it is coming from the de novo lipogenesis and from the carbohydrate origin. Now what is this ugly fat? That is the ectopic fat. So ectopic fat is metabolically unhealthy diabetogenic obesity. So in this cartoon you will see that the fats are deposited perivascularly in the myocardium itself, liver, pancreas, kidneys, and visceral adipose tissue, and intramuscular fat. So the fat stored in the organs, mainly the liver, muscles, skeletal, cardiac, smooth muscles of the arteries, pancreas, blood vessel walls, and the adipose tissues themselves. So what does it do? Ectopic fat does give rise to dysmetabolism by causing insulin resistance, inflammation, lipotoxicity, and dyslipidemia. Now I will take you back to the Whitehall study, which was a study which was published, in which they found out that the nurses who had diagnosis of diabetes at this stage, and they had a chart study of 15 years prior to their developing diabetes, they found that the blood sugar gradually went up for 10 years, from 90 to 100. It took 10 to 12 years for this progress, and after that, just 2 years prior to the diagnosis of diabetes, the blood sugar started going up very sharply, and then the diagnosis of diabetes became evident. My point in telling you this is that dysglycemia begins 15 years prior to the diagnosis of diabetes. So I have been always telling that we must change the word diabetes into dysglycemia, because that is the underlying factor of diabetes. I tried to formulate a hypothesis why we develop diabetes, type 2 diabetes, how it develops. So if we consider, this is the green is that the normal blood sugar goes up. White House 2 study we have seen, it grows up gradually and then it goes up. So not only does the glucose, but it is the free fatty acid. Both of them go together. So not only fasting glucose goes up, but the fasting fatty acid levels also go up. So lipolysis is because of the fatty acids. And then I have tried to make a differentiation between the high fat diet and a high carbohydrate diet and showed them separately, though in practice it cannot be so. Our diet consists of fats as well as carbohydrates. But suppose if you are eating only fat diet, then you will find that your subcutaneous fat will go up. Your insulin, which is shown in the blue color, will also go up with that subcutaneous fat. And this is how insulin as well as the subcutaneous fat will go up, but the sugar will not go up. Now take a condition where carbohydrate excess occurs, you will find that the visceral adiposity now increases, and at the same time insulin also will increase along with visceral adiposity. But this visceral adiposity will cause lysis of the subcutaneous fat, and that is why the subcutaneous fat will come down, and at the same time the ectopic fat will also come up. This is the mechanism of the Whitehall tube phenomenon, and this is over a period of 10 to 12 years. Now you will find that here there is hyperinsulinemia. Insulin increases more than glucose, and that is the insulin resistance. That is what is mathematically seen. Now you will appreciate that after this there is a fall in the insulin level. And what is this peak? So this peak is the storage of fat has a limit in the body. So how much fat can be stored either as a visceral fat or a saturated fat has a limit, and this limit has three factors. One is that it has an IGF-1 peak. So the growth hormone, how much we can grow and up to what level has a limit, and that is the IGF peak. Then the organ fat saturation means how much fat can be stored in the organ also has a limit. And the adipose tissue insulin resistance. So people who are born with resistance in the adipose tissue, insulin resistance, they will have a early onset of diabetes. So thin diabetes people. So usually we come across a garden variety of obese type 2 diabetes, but people who have an inborn adipose tissue resistance, they will develop diabetes at an early age. Here also I would like to tell you that the beta cell function decline will start here, and at 50% of beta cell loss, you will diagnose the person with pre-diabetes. At 20% of beta cell function loss, the person will be diagnosed as type 2 diabetes. So here, a big long thing. Here you will find that the gliptins, the GLP-1 and the GIP, they are all suppressed during this phase, and the hypoinsulinemic phase will start here, which will resemble like type 1 diabetes. Now, next few minutes I'll just tell you about an investigation that is very useful in clinical practice, that is DEXA scan. I have been using bioelectric impedance in my practice, and which is not very accurate, but DEXA scan is very accurate. Dual energy X-ray absorptiometry. It's a very simple investigation which will tell you where and how much fat is stored and where it is exactly stored. However, DEXA scan cannot differentiate between visceral fat and ectopic fat, but it will definitely tell you how much visceral fat you are having. So in this cartoon you will find that this this is the fat which is represented in yellow, muscle is represented in red, and the bones are represented in blue. And therefore you will find that this gentleman has hardly any fat, this person has lot of fat, most of it is a subcutaneous fat. Lot of other things are here which I will not go into the detail. But what is more important, which I want to tell you, is what we are using is a body mass index. So body mass index we have been hearing from many speakers since morning. DEXA gives us another index, that is fat mass index. Body mass index is defined as weight divided by height square. Here we are using fat content, fat mass of the body divided by height square, and they have defined that upper limit is 9 in female and 6 in males. Anything more than 9 in female, 6 in males is obesity. So obesity type class 1, class 2, class 3 can be defined by just adding 4 numbers to each step. So 9 plus 4 is 13, 13 plus 4 is 17, and here 6 plus 3 plus 9 plus 3, 9, 12 plus 3. So for males add 3, for females add 4, and that will give you a good classification of obesity. Then reference values for DEXA scan. Very important to risk stratification. So DEXA scan will give you fat mass in kilograms, it will give you body fat percentage, it will give you a fat mass index. I told you it is 3 to 6 for men and 5 to 9 for females. Android to gynoid fat ratio. Very important what we are doing, waist to hip ratio. Same thing is android to gynoid ratio in DEXA scan, which is less than 1. DEXA scan beautifully calculates the visceral adipose tissue, which should be less than 100 square centimeters. So if it is less than 100, it is normal. More than 160 is supposed to be metabolically high risk. Then subcutaneous adipose tissue, that SAT, that has no limit, it can be anything. VAT to SAT ratio should be less than 0.4. Appendicular lean mass index. What is that? That is the how much muscles you are having in the upper and lower limbs. That is known as the lean body mass index or the skeletal muscle index. So in a sarcopenia, it should be more than 7 for men and more than 5.5 for women. If it is less than that, it is sarcopenia. Two serial investigations will give us very important and very useful information. This is DEXA scan, how visceral fat is calculated. You take a transverse section, this is visceral fat, this is subcutaneous fat. You subtract this total fat minus subcutaneous fat is visceral fat. So this is one is the visceral fat, this is subcutaneous fat. This is how the subtraction is done, and this is how they calculate the visceral fat area, which is a very important parameter. This is the last slide. Body composition with DEXA from basics to new tools. So these are the new tools which we should be using in clinical practice. The clinical importance of visceral adiposity is widely recognized, as it has been showed that VAT is a better predictor of mortality than the SAT or the AG ratio. So even android-gynoid ratio or waist to hip ratio, VAT area is much important. Thus, it is possible that VAT will replace AG ratio as a risk factor for assessment of CVD risk with DEXA. I told you that first 12 years prior to developing diabetes is CVD risk. There the hypertension occurs, there the triglycerides go up, there is a risk of stroke during first pre-diabetes area. It is important to consider even subjects with normal values of BMI may have an increased amount of VAT accumulation, thus being the higher risk for estimated only for conventional anthropometry measures. So the point here I want to make is what Dr. Yadnik has told us, that thin outside, fat inside can be documented by calculating actually the VAT area from the DEXA scan. This is much better clinical tool than using other grading for obesity. We are carrying out a Sulata Nirmulan Karyakram in our clinics, scientific reversal program, which is based on giving the Dean Ornish's or the Dr. Roy Taylor's program, and we are trying to analyze our results also. We are getting very good results with our program.